Hi, everyone. My name is Samreen Aziz. I am a second-year Master's of Applied Sciences student in Biomedical Engineering at Carleton University. My studies are under the supervision of Dr. Jim Green in Ottawa, Ontario, in Canada. Thank you for taking the time today to listen to my talk and to MEMEA for the opportunity to present my work. My presentation today is about the detection of neonatal patient motion using a pressure-sensitive mat. The following is an overview of my talk for today. I will begin with an introduction of our project, talk about the PSM technology, describe our methods and results, and end with some discussion. The NICU, that is, the Neonatal Intensive Care Unit, treats the most fragile and sometimes preterm infants who are also physiologically underdeveloped. Such patients require consistent monitoring of their vital signs, including their breathing rate and blood oxygen levels, to name a few. However, in monitoring infants, adhesives are used that can irritate fragile skin, and then there are wires that may complicate care and cause discomfort. This is what a typical infant in the NICU undergoing consistent monitoring looks like. As you can see, many wires and many adhesives, not a pleasant situation. Therefore, there is a need for non-invasive monitoring solutions for such patients. In our research, we are exploring a novel sensor in the NICU, the pressure sensor mat, or the PSM, which is 100% non-invasive. It is placed between the mattress and the bedding, with a sensing area containing 10,000 sensors. In developing an unobtrusive neonatal monitoring system, our team has three non-invasive goals and criteria. 1. To monitor vital signs such as heart rate and respiration rate. I would like to mention that our team has successfully been able to use signals from the PSM to estimate respiration rate with a margin of error of 5 beats per minute. 2. We would like to detect patient movements. And 3. By detecting patient movements, we would like to be able to document and classify clinical interventions. The following is a description of the subjects used in our study and our experimental setup. As you can see, the pressure-sensitive mat captures time-varying contact pressure signals from 0 to 3.41 newtons per centimeter squared. It is in ID 1 in the image on the right, and it is placed between the bedding and the mattress. During the 4 to 6 hours of recording, using our temporal event annotation app, 2 bedside annotators record patient movements, routine clinical care events, clinical interventions, and physiological events like crying or coughing. Did you know that over 50% of alarms in the NICU are false? This can produce overworked care staff in the NICU, possibly skewing their reporting accuracy and care efficacy because of fatigue. We hope to use motion detection to assist in gating motion artifact-related false alarms in the NICU. We will use the center of pressure, or COP, obtained from the PSM to distinguish between segments of neonatal movements and the lack thereof. The total distance traveled by the COP, as per our hypothesis, between successive seconds summed over a sliding window can be used with a decision threshold to identify periods of patient motion. This brings me to a more specific definition of the center of pressure. The center of pressure is the area-weighted sum of all forces to the PSM. The COP has been shown to be useful in providing insight into human movements, in the analysis of the stability of human gait, and to identify differences between bed exit and sit-to-stand COP signals. In our study to identify patient motion, we selected 30 to 180 minutes from each of 5 patients, 4 for training and 1 for testing. We isolated only those annotations of gross motion and no motion, and downsampled the data by averaging from 18 to 1 frame per second, so we would have 1 representative COP coordinate pair per second. There is a difference in COP behavior during a period of motion and a period of no motion. In B, over a period of approximately 20 seconds of no motion, the COP moves about in one small area, which is likely due to breathing motions in the abdominal region. As you can see, at a period of rest, the center of motion lays in the abdominal region, as shown in image A. During approximately 20 seconds of motion, the COP travels a significantly larger distance than during no motion, as shown in image C. This can be further shown in the videos following. So as you can see on the left here, we have no motion. We have the center of pressure at a period of no motion. So it's just moving about in a small area in the square showing the region where the center of pressure is. It doesn't seem to be moving too much or creating large distance trails. Whereas on the right, you have the center of pressure during a period of motion, creating larger, more elaborate distance trails. And it's a bit more dramatic in how it moves, just like it is happening right here. So you can see the differences in distances being traveled by the COP during motion and no motion periods. As such, we decided to measure the sum distance traveled over periods of motion and no motion as our key classifying features. For each episode, we convolved with a +1, -1 filter to compute the first differences between successive seconds. We computed Euclidean distances and then used a sliding box filter to sum those differences over a window of wind length. Given human error in annotation is quite possible, for example, there may be a lag in capturing the start and end times for a movement episode, we skipped the first and last num-skip seconds within each episode. The sum distance for each window was then compared with the distance decision threshold separating motion and no motion for classification. The selection of how large a window is and how many seconds are skipped at the beginning and at the end dictate the separation between motion and no motion, as well as the decision boundary. How large these parameters are also dictate how many events are included in this histogram, which suggests how much overlap there will be and how accurate the decision boundary will also be. We see that no motion typically has a sum distance closer to 0, and motion is greater than 0.5 or 1, typically clustering around 2 to 8 centimeters. Now that we know that num-skip, window length, and threshold all impact the quality of classification, we needed to find these optimal parameters. We start with the window length and the skip length. We performed a grid search to find pairs of parameters for each patient that performed optimally, using AUC as the performance metric. Then, to make sure the parameters are generalizable and not just patient-specific, we tested each optimal set of parameters on every patient. Then, we averaged the AUCs for each parameter set. We then found that the best performing parameter sets of window length and num-skip respectively were 5.5 and 7.3. As you can see here, the ROC curves for these parameter sets used on a patient different from the original patients, which were patients 6 and 10, are excellent when applied on patient 2. This speaks actually to the robustness of the algorithm that we are applying. We then moved on to checking if these parameter sets stay true in their excellent performance by searching through optimal thresholds for each parameter pair across every patient and evaluating them based on classification accuracies. After averaging the accuracies and thresholds across each parameter pair and across all patients, we found that the parameter sets 5.5 and 7.3 still had the strongest average classification accuracy across all optimal thresholds. Given that we were looking for one parameter set, we averaged the two best performing parameter pairs and found a window length of 6 and a skip length of 4. We tested all patients with this parameter pair and found an excellent average performance accuracy of 90.9%, and more importantly, a general threshold of 1.7 centimeters. However, to deploy this system, we needed to determine one that worked on all patients. Could this set work on new never seen before patients? And it did. Along with the classification threshold, testing on patient 8, we found that its performance using the generalized parameters was excellent, producing a classification accuracy of 93.4%. Looking at recall, there was a reduction by only 0.041. However, there was an increase in accuracy by 2% in order to compensate. There is no need to use patient-specific parameters when generalized parameters work very well. The generalized parameters require an episode of at least 14 seconds in order to detect movement. That is, the window length and skip length values preclude analysis of smaller episode lengths. The model appears to generalize to different patient masses. The training patients were of our max weight category, which is greater than 2,500 grams, while our testing patient was a mid-weight category, 1,500 grams to 2,500 grams. The question is, can our model extend to low-category birth weight patients? In future work, we hope to expand our methods by leveraging COP behavior further to differentiate between upper and lower body movements and externally and internally induced motions. Further, this work will be expanded into real-time deployment. We will test patients of different weight classes. Since all training patients in our current work were greater than 2,500 grams, we will need to validate on lower mass patients. If our patient monitoring system can detect patient motion and further classify specific events that are internally or externally induced, this can contribute towards work in developing an automated charting system for nurses in real time. This is so care teams can spend less time doing that which is here on the left, charting and trying to stay on top of all the minuscule details, and more time doing that which is here on the right, which is giving the newest members of our world the time, care, and attention they need to thrive outside of the hospital walls. Here is our team working at Carleton in the Biomedical Information Collaboratory, supervised by Dr. Jim Green. Thank you so much for your time and attention. If you'd like to contact me, I have my email here and my LinkedIn if you would like to connect. Thank you so much once again for your time. Please enjoy the rest of the conference.